Good afternoon, everyone. I'm Paul Ong. Welcome again to another session of APEC-I webinar. Well, today our focus is looking at PCI in advanced chronic kidney disease, when less contrast is more. I'm really privileged today to have two of my good friends in the studio joining me to co-host these sessions. So together with me is Professor Jack Tan. Probably doesn't really need a lot of introduction. He's currently the president of our APSC. Household name. Everyone really is, friends everywhere, and he will be very helpful joining us and try to modulate the sessions. Together with me is also Dr. Ho Hee Hwa, my long-term friends, close colleagues, and also more importantly, he is the brain behind this series of webinar. Why did we pick this session? This is actually our first APEC-I webinar for 2021. And I look at that very uplifting opening scenes, and I really be keen to see some of you come and visit us in Singapore. And we were talking, we are really desperate to try and visit you in other parts of Asia as well. While we are planning our sessions, we thought a lot of us, when we do angioplasty, we're gradually doing a little bit less contrast and using more intracoronary imaging to substitute that. So maybe a lot of us also have the encounter with patients with quite severe chronic kidney disease. And when it comes to treating them, investigating them with angiogram and treating with angioplasty, there's that dilemma whether the patient will accept it and whether we might actually cause contrast-induced nephropathy. So I want to try and get you all to be involved and more engaged. So I want to prepare some polling questions, and I'll be really encouraging you to participate in some of the polling questions. So just to test it out, maybe can I have the first polling question up? And I'd like to see how, in your practice, what do you see? So how often do patients with advanced CKD decline angiogram or angioplasty in your practice? Often, all the time, or just sometimes? So I'm going to leave this slide up for a little bit and see how to gauge it. And I'll be keen to see that you're all able to participate in this polling. And throughout today's lectures and webinar, we'll encourage you to participate in polling, and we'll also in particular encourage you to pose questions where my co-modulator will help direct them and ask them on your behalf. Okay, so we can see here almost, sometimes and often. So these are real world issues and dilemma that we have to focus on. Okay, I'm going to stop here, and I'm going to pass over to Dr. Ho to introduce our expert panelists and speakers today. Over to you, Kewa.
Okay, thank you very much, Paul. So I think like what Paul mentioned, the emphasis for today's webinar is on ultra-low contrast PCI, and we're going to highlight the features of the SynVision system. So for our faculty, we are pleased to have our faculty all the way from UK, which is Dr. Bilal Patel. And we also have our friends around the region. We have Dr. Michael Lee from Hong Kong. We have Dr. Donnie Furman from Indonesia, as well as Dr. Nicholas Cruz from Philippines. So the agenda for today's webinar is we're going to have 2 lectures followed by a live in the box, and then another complex case sharing by Dr. Bilal Patel. So without further ado, I'm going to pass over to Jack to introduce the first speaker.
Welcome, everyone. It's my great privilege and pleasure to introduce Dr. Michael Lee. He's the head of cardiology at the Queen Elizabeth Hospital from Hong Kong, the president-elect for APSIC, and the founding course director for Hong Kong STENT. We all know Michael very well. He's very well known in this region and many parts of the world. And he does coronary structural interventions extremely well. Today, he's going to give us a talk on PCI in advanced CKD patients, the challenges and the complications thereof. So we welcome Michael to give us our opening lecture for this afternoon. Thanks, Michael.
My invitation. I'm glad to participate in this meeting. So what I'm going to do is I try to set the platform for further subsequent discussions on how we can actually perform PCI safely in patients with advanced chronic kidney disease. So I have no conflict of interest here. As all of us know, cardiovascular disease actually is the major cause of death in patients with chronic kidney disease. It has been estimated that 50% of end-stage renal disease patients actually die from a cardiovascular cause. And 40% of patients who, at the start of their dialysis, might have some sort of cardiovascular disease. And this problem is actually more severe or more important in younger patients because when a young patient with chronic kidney disease compared to general population, they might have actually a 500-fold increase in the risk of cardiovascular mortality. And this cardiovascular risk actually also increases with increased severity of chronic kidney disease. You can see that when they reach stage 4, stage 5, and then subsequently end-stage renal disease, the risk of cardiovascular mortality or other morbidities actually increase quite dramatically as compared to a patient with no chronic kidney disease at all. So inevitably, we have to offer some sort of treatment for these sort of patients when they have such high cardiovascular risk. So these are the analysis of patients with and without chronic disease going for PCR. You can see that for patients with chronic kidney disease, these are the survival curves. Their survival after PCI is actually much worse than patients without chronic kidney disease. And their MACE-free survival is also a lot worse than patients without chronic kidney disease. That means they will have a lot more anticipated complications when they have to be put on treatment such as percutaneous coronary intervention. And during the intervention or subsequently afterwards, they might have actually increased bleeding complications. And it's even worse that the risk of major bleeding actually is a lot more in this sort of chronic kidney disease patients. So, we have to develop sort of a practical approach to treat this sort of chronic kidney disease patients. So there are a lot of parameters to look at. I would say when we look at the risk factors of these patients, we have to take into account their comorbidities. A lot of them are diabetic patients with a very high lipid profile, and a lot of them are actually having a reduced left ventricular function. Anatomically, these patients have very calcified coronary arteries. A lot of times it happens in the left main bifurcation lesion. And these patients also, after the procedure, they might have a lot higher bleeding risk, and their compliance or the proper use of DAPT together with some sort of novel anticoagulants might be a big problem for the clinicians. So these are the different scoring systems, the discussion that we should discuss with the patient. But all in all, I will always treat these sort of patients as our complex, high risk and indicated patients. And a lot of these patients might actually end up needing high risk PCI procedures with some sort of mechanical circulatory support device. The calcification is a particular problem in these sort of patients. They have a lot more common promoters of calcification in this group of patients, as you can see from this list. So no wonder that when we come across these sort of patients, they present to us a lot of times very calcified, very difficult to handle coronary artery. So a lot of time we have to resort to some sort of atherectomy devices, whether it's rotational or orbital atherectomy, and a lot of times lithotripsy balloons as well, to help us with this PCI procedure. This would inevitably increase the risk of PCI in our daily practice. The more common problem might actually be further kidney injury after the PCI because of the contrast that we are giving to the patient. And if you look at patients with increased severity of chronic kidney disease, actually they have a lot more incidence or a lot more probability of acute kidney injury. So like for patients with GFR less than 30, 1 in 4 of them might end up with acute kidney injury, and about 4 to 5% will end up requiring dialysis. Apart from the kidney problem, actually, these patients also present with a lot of other comorbidities or other clinical conditions that would put them at increased risk of acute kidney injury. Some of them might end up needing IBP support. Some of them present with STEMI or even in cardiogenic shock. So all these all compound together to add to the risk of acute kidney injury in these sort of patients going for PCI. Roxana Meringue actually has suggested a scoring system on how we can predict this sort of post-PCI contrast nephropathy, depending on whether the patient have hypotension, whether he or she needs IBP, whether there's a heart failure, elderly, anemia, diabetes, and so on. And also the contrast volume that we are giving, as well as the underlying impairment of kidney function. So you can see that when the risk score is very high, like more than 16, you can see that the risk of contrast-induced nephropathy actually is more than half. And risk of dialysis, more than 10%. So this is something that we can calculate beforehand, and then we can communicate with the patients before we even start. So you can see that patients with chronic kidney disease are at a much, much higher risk of acute kidney injury. Of course, we will try our every means to try to optimize this revascularization procedure. So nowadays, we will try to involve our nephrologists as well, what we call a heart kidney team, ask them to get prepared for these sort of patients, whether they need dialysis in the future or not. On the other hand, we are also talking about what we can do during PCI. We can also use ultra low or even zero contrast, which I will elaborate later on. And then hydration is actually very, very important for this sort of patients. So the general principles in this sort of prevention of contrast-induced nephropathy all depends on the less contrast volume and the better hydration that we are going to give to our patients. So if we look at the contrast volume, you can see actually the more contrast you use, the higher the chance that you will end up with acute kidney injury to these sort of patients. So if you look at when we are using more than 300 mils of contrast, there's a dramatically increase in the risk of acute kidney injury. So there's actually, when we use every 17.5 mil more contrast, we can actually predict there's increased risk of AKI by 42%. So this comes to my first polling question. I want to ask you, just want to know, what is your upper limit of contrast volume when you are going to do a PCI for chronic kidney disease patients? Is your upper limit 50, 100, 150, or 200 mil? It's mils, it's cc, right? So you can actually vote. 100% 50. Now it's half-half. I guess you need 2 responders. All right. So the principle is try to give as less contrast as you can. Maybe we can go back to the slide. So majority of you will use as less contrast as possible, 50 to 100 mil. Actually, I should give you an option. It all depends on the underlying renal function of the patient. So there are suggestions when we should actually stop using any more contrast for this sort of renal patients. Usually, we will use the most lenient criteria, the first one, the eGFR times 3.7 mil. So you can imagine for patients with eGFR of like 30, then the maximum amount of contrast that you can use is around 100 to 110 mil for the whole PCI procedure. In fact, if you can use less contrast, like ultra low dose or even zero contrast, then the risk of acute kidney injury is much less. So this is a paper written by Syed Ali a few years ago. It looked at 31 patients with almost very, very impaired renal function, eGFR 16. he gave a zero contrast during the PCI procedure, mainly directed with the IFUS guide, and end up with 0% of acute kidney injury and 0% of these patients going up for dialysis. So my second polling question would be, we know fluid is very important, hydration is very important. So for patients with chronic kidney disease going for PCI, how much fluid would you give? And what are the parameters that you will look at on deciding how much fluid you will give? Is it on clinical assessment? Is it on LVEDP, urine output, or according to the blood test that you received just before the interventional procedure? I'll give you a few seconds. So I think all these are important parameters to look at. Okay, half and half clinical assessment and LVEDP. So all these are very important assessments to look at, but in our opinion, what's more objective would be the LVEDP. Let me go back to the slides. Half. So this LVEDP guide fluid administration actually has helped us a lot in actually giving adequate hydration of the to the patients and then end up with less AKI. So what they have suggested is they give fluid before the procedure, 3 ml per kilogram bolus, and during the procedure, the amount of fluid will be decided by the LVEDP. So if the LVEDP is low, they give more fluid. If the LVEDP is high, more than 18, they give much less fluid. And then this fluid has to be continued for the next 4 hours at the same rate. So by doing this, patients in the LVEDP guide group will actually receive a lot more fluid as a hydration volume, and then resulting in much less contrast-induced nephropathy at the end. And it has also been shown recently that for patients with AKI, as I told you, they might have to go out for high-risk PCI procedures. And it has been shown that with the help of mechanical circulatory support devices, in particular the impeller device, actually patients will end up with much less acute kidney injury as compared to patients without support. So this is something that we can consider again for high-risk PCI patients with chronic kidney disease. So I just want to show you a case that we did not long ago on how we can apply these principles to help out our patients. The 80-year-old gentleman, diabetes, AF on warfarin, and he presented with exertional angina with echo actually showing severe aortic stenosis with preserved ejection fraction. Unfortunately, coronary angiogram show a severe left main bifurcation and also diffusely diseased LAD and left circumference. His creatinine clearance was only less than 25, around 24, 25. So we used very, very low contrast to do the diagnostic angiogram. But this was the only one shot of the right, which you can see there were some stenosis, but not really particularly severe that weren't interventional procedure. But when you look at the left side, you can see that the LAD was diffusely diseased, circumflex was big vessel, also diffusely diseased, and then there was a left main LAD bifurcation lesion, which would require complex stenting for the procedure. So with such a kind of patient, severe AS, triple or at least 2 vessel disease with severe left main bifurcation, we actually asked our surgeons to take up the patient. But the patient actually is sort of wheelchair bound outdoor, a high frailty score and a high SDS score, and he was actually turned down by our surgeons and actually referred back to us for consideration of PCI and then TAVI procedure. So what we did is, as our protocol driven, we actually pre-hydrate the patient. We use left radial approach, try to do sort of ultra low contrast or contrast-free PCI, try to reconstruct the left main bifurcation lesion. So we actually use the guide wire, bring the guiding down to the left ventricle and measure the LVEDP, and then subsequently give fluid for this particular patient according to the protocol. So this was our procedure, left radial approach, 7 French slender guy, EBU 35. So during our sitting of the guy, actually we didn't even give contrast to make sure our guy was in position. What we did is after we think it's engaged, we just give some sort of saline flush, so that if we see the ECG change, you can see the EKG changes after this saline flush. Then we know we have engaged the left main. So subsequently, we actually brought up our diagnostic angiogram as a roadmap, and then try to get the same projection and then fire the LAD according to this roadmap. And then the same for the circumflex. And then we actually started, because the lesions were very, very tight. We couldn't actually pass the IFUS star. We started up with a 2.5 NC balloon and then followed by a 3.0 scoring balloon. And then we performed IFUS for this particular patient, and you can see the IFUS results here. Very, very stenotic lesions at some part of the LAD, and then some of them are actually very, very calcified, 270 degrees out of calcium. So after adequate predilatation, we actually performed sort of a very prolonged stenting, long length stenting for this particular patient with a very, very long stent, 2.5 by 48. So what we have done is we tried to use the IFUS to mark our most distal lesion and then the proximal lesion, and then use this as a roadmap to guide our stenting position. So this was our first stent, 2.5/48, and then our second stent, 3.0/33. And then we went to the left circumflex, again, predilated with the NC25 balloon, followed by 3.0 scoring balloon, all the way from distal to the very proximal. And then this was the 3.0 scoring balloon. And then we did an IFUS run as well for the circumflex. We see very, very stenotic artery, coronary artery as well. So again, IFUS guide stenting. The first stent was 2.5 by 38. The second one was 3.0 by 18. And then to be more exact, position the circumflex osteostenting at exactly the ostium of the left circumflex. We actually use the Szabo technique, and we have sort of, you all know the Szabo technique, right? We just pass the guide wire outside the patient's body, the most proximal part of the stent strap, and then try to push the stent in. Yeah. So what we have done is sort of a Szabo single string Coulomb technique. We just try to reduce the metal that will be overlapping with the LAD stent. You see, this is how we push the stent in, get a good position. This is a 3.5 by 23 DES, and then we deploy the stent, and after that we actually perform an IFUS run. You can see that we can actually see the guide wire of the LAD in this particular position, so that we know actually we have been performing what we call the single string Coulomb technique. So minimal overlap, minimal metal at the left main LAD region. Then we actually pass 2.0 balloon followed by our 3.0 balloon to the LAD, try to dilate the single string strut of the stent, and then put in a final 3.5 by 23 DES from LAD to the left main. This was how the stent was put in, dilate. And then actually we went back to rewire the circumflex, and then individually post-dilate, optimize the stent at the circumflex and at the LAD, and then kissing balloon angioplasty followed by final port at the left main. So, and then we actually get an IFUS run again for both the LAD. This was the LAD IFUS run as well as the circumflex IFUS run. And then when we are all satisfied with our results, we performed a final angiogram. You can see that this was the first angiogram that we performed throughout the procedure. sort of what we call the legal shot, just in case the case was brought to the court. So we have something to show to the judge. So you can see that the LAD circumflex left main was well tackled. So our total contrast volume only with these two shots was 6 mils only. We have only used 6 mils for this complex bifurcation single strain Kulak, and they use the SAPO technique. And then we stage the patient for contrast-free TAFI procedure at the end, sometime later. So this was the renal function that I have captured for you. The procedure was done in June last year, and this was subsequent days. You see that there's at least no further impairment of the renal function with our use of sort of very, very minimal contrast, ultra low dose of contrast. This was our contrast-free TAFI procedure. A few weeks later, you can see actually we mark the 3 aortic cups with 1 pigtail and then 2 E18 guide wire, and then deploy our Evolut TAFI device. And then at the end, we actually didn't use any contrast, zero contrast for this particular TAFI procedure. No TEE, we just used the TTE at the end of the procedure just to make sure that the TAFI device was adequately placed in good position and without much regurgitation. Okay, all right. So my take-home message, sorry for that. My take-home message is coronary artery disease is very, very prominent in patients with chronic kidney disease. And if we are thinking of performing interventional procedures, PCI for this of chronic kidney disease patients, we will put the patient at increased risk. So we have to use our every means to try to reduce the risk of PCI in this of CKD patients. First of all, calcium modification is very important. Scoring balloon, rotablator, orbital atherectomy, short wave balloon. We use everything we can try to optimize the result, try to modify the calcium. And then we have to provide the patient with adequate hydration, LVEDP guide hydration, and then try to use as less contrast as we can, IFUS guide, ultra low, or even zero contrast PCI. That's all I want to share. Thank you for your attention.
Check.
Okay, check.
Thanks, Michael. You delivered a wonderful lecture. It was a really amazing case. Actually, I want to ask around your front part of the lecture, which is less so about the technical piece, to Dr. Nick Cruz. I saw in your CKD group this issue of a diabetic patient, the need for complex PCI calcification, and the high bleeding risk. So I want to ask Nick, what is a pharmacotherapy around this group? How do you balance between choosing a DAB therapy with clopidogrel versus a third generation tirupyridine? What is your practice? Nick?
Yeah, hi, Jack. Thank you for the opportunity, Jack. We try to follow the new ESC guidelines on high bleeding risk patients. So we minimize the need for dual antiplatelet as much as possible. Of course, you have special stents that you can use the APT for a month. And then stick to the guidelines of using a single anticoagulation, an anticoagulant plus a single antiplatelet. Again, most CKD patients are automatically high bleeding risk patients. So it's very important that we do adequate preparation, as Michael has mentioned, in order to decrease the risk for stent thrombosis. So just to focus on your question, Jack, it's a DAPT for a month, and then continue the anticoagulation with a single antiplatelet after a month.
Thanks, Nick. I also like to ask Donnie, actually. You saw the wonderful case done with 6 mil, bifurcation, multiple stent case. Who should be doing this type of cases? Is it what kind of experience level? Maybe you can give our audience a gauge of where you should be before you attempt this.
Yeah, I think it's a very, very wonderful case, Michael. Congratulations. I enjoy your case very much. So this is a very challenging case, I think. to have a 6cc on the very complex is very, very amazing. my least contrast in my CKD patient, I think around 15cc. That's the minimum contrast I have. And then by using the Philips system, the Sync Vision is very helpful in my experience, using tri-registration, combining between IVUS and then also IFR. Also helping us to deal with this kind of situation, and then can help us to reduce our contrast. So in my experiences, like Michael, but not as amazing as Michael, our Philips system is helping us so much. Jack.
Thanks a lot. We're going to move to Bilai's lecture, so hopefully we can bring back one piece later at the case in the box. Hiwa?
Yeah, so it's my pleasure to introduce Dr. Bilal Patel. He's currently a consultant cardiologist working in the Blackpool Teaching Hospital, United Kingdom. And he has considerable interest in patients with performing PCI, with patients with advanced CKD. And he was going to share with us the tips and tricks for using Sync Vision in performing ultra-low contrast PCI. Over to you, Bilal.
Thank you very much for the invitation, and it's a great honor to be speaking at this conference. And congratulations for a fantastic presentation and a really great case. So my talk is on tips and tricks for ultra-low contrast PCI using Sync Vision. This is my conflicts of interest. So the first question, poll question 1, is, who has got access to IVUS core registration? And the second question is, do you think IVUS core registration is a useful tool? And while people are answering the poll, I'll carry on with the talk, and we'll just go back and have a quick look at the results shortly. So the objectives of this talk is, are we utilizing new technology well? Is there a role for IVUS core registration in the cath lab? Do we need to reduce contrast in PCI? What are the ways of doing this in the lab? How do we do it practically, step by step, how to use Sync Vision for core registration and doing tri-registration with minimal contrast, and how to get the best of the system? So cardiologists, interventional cardiologists, really, we need to be a mix of optimists and pessimists. We need the optimists to provide innovation, and you need the pessimists to make sure that we don't go overboard, but really we need a fine balance to make sure we push the boundaries, yet at the same time, we maintain safety for the patients. And if we turn back the clock, we see that in the field of cardiology, there's been really great advances, developments of technology and innovation, and this has resulted in a significant reduction in cardiovascular mortality. And like when you're planning any sort of journey, you need a roadmap, you need your tools of navigation, and these can be fairly old school, or you can use technology to your advantage. In interventional cardiology, the goal at the end of the day is to get a patient with complex disease out safely with an excellent result, which will give them a very good long-term outcome. Now, we know that mostly in the cath lab, we rely on coronary angiography, and we know it's all about perspective, and we get a 2D image and we take multiple views to give us, what we think is going on inside the vessel. But using intracoronary imaging, we get a really good view, cross-sectional image of what's going on in the vessel. And there's growing evidence that using intracoronary imaging improves outcomes. We see from the ultimate study that the difference between IVUS guidance and angiography guidance is a significant reduction in target vessel failure. And we also know in patients who have got optimal outcome with IVUS do significantly better than those who do not have an optimal outcome using IVUS. Large meta-analysis does show relative reduction in cardiovascular death and reduction in stent thrombosis, target vessel revascularization, and myocardial infarction when we use IVUS. And in patients with CKD, generally the outcomes are worse compared to patients without CKD. However, if we use intracoronary imaging in these patients, we find that there's a really marked improvement in outcomes. So in this group of higher risk patients, there's a growing argument of using intracoronary imaging anyway. So now we go to new technologies. So Sync Vision is IVUS core registration that allows us to co-register the angiogram with the cross-sectional images of the IVUS, and using the yellow tracker, you can track the vessel up and down, and this will show you where you should be on the angiogram. Now, we know with a lot of new technology that sometimes it can be seen as a gimmick, and is there really any practical application? Or is it going to end up on the scrap heap, you know, in a few years' time, like these pair of shoes that also act as a vacuum cleaner? So is there a role for IVUS co-registration? So IVUS co-registration can be very handy, you know, to guide where you're going to stent, your proximal distal landing zones, plaque burden, the size of the vessel. So it can be useful from that perspective. But in, you know, actually doing day-to-day PCI, is it really helpful? So this is a case I've got of a heavily calcified vessel that underwent rotational atherectomy. Despite rotational atherectomy, we were unable to get balloon expansion. We did an IVUS co-reg, and on the IVUS co-registration, it quite nicely shows 4 areas of concentric ring calcification. So we were able to use the co-registration technology to help targeted therapy with shockwave. And we targeted 20 bursts to each of these 4 areas where there's concentric calcification. We repeated the IVUS run, and it shows quite nicely there's disruption of the calcification. And then we were able to deploy our stent with a good result. So is there a role for reducing contrast in PCI? Now, I'm just going to quickly go back to the poll answers regarding IVUS co-registration. Can we just put the answer up for us? And I think I've got on my poll that 100% think it's a useful tool. So, you know, do we need to be reducing contrast generally in PCI, particularly in the CKD patient? Now, we know the patients with chronic kidney disease have got a worse cardiovascular outcome, worse mortality, and also they've got far severe pattern of disease as demonstrated in the previous case, often involving left main stem and calcification. And this group are a group that historically are underserved when it comes to invasive assessment, yet this is the group that has got the highest mortality. We also know that in this group of patients who undergo myocardial infarction with CKD, they do benefit from revascularization. Even the patients with very end-stage renal disease benefit from undergoing revascularization. We saw this slide previously. The worse your baseline renal impairment, the greater your chance of ending up with contrast-induced AKI and requiring dialysis. So is our fear justified? If you develop contrast-induced nephropathy, your mortality is around 25% at 12 months. And you know, another study shows that actually the curves continue to diverge. So really, for the interventional cardiologist, prevention of contrast-induced AKI is really something we should be trying hard to achieve. Now, the pathophysiology is complex. Contrast has got a direct toxic effect, causing constriction of the blood supply to the glomerulus. But it's not just about contrast. In this group of patients, there's other factors that causes acute kidney injury, often to do with embolization, shock during the procedure. And these patients, as we know, are at greater risk of bleeding. All these are factors as well that can cause acute kidney injury post-procedure. So we can think maybe our fear is justified of this group of patients, and you know, we bury our head in the sand and avoid taking these patients to the cath lab. And we can see why that might be, because you know, this patient with kidney disease and quite advanced coronary artery disease, we have the fear of these patients going on dialysis, because that does mean that they end up with a worse outcome. So how can we reduce contrast practically? You know, we can reduce contrast by diluting down with 50% saline and 50% contrast. We can use technology in the lab such as Stent Boost. Sync Vision allows device detection. And then there's a piece of software called Dynamic Coronary Roadmap, which overlays the image in red of the angiogram you've taken, and then allows you to use this as your roadmap when you're wiring the vessel. We know that use of IVUS can be very helpful. And we can use things like metallic wire roadmaps with wires, so you can place multiple wires showing you where the side branches are. Then you've got IVUS co-registration using Sync Vision, which is what this talk is about. However, I know that a lot of people, however, though, you know, may not have access to Sync Vision and co-registration, but you are able to do these cases just using standard IVUS. And while you're doing your IVUS pullback, you do multiple episodes of screening and bookmark the IVUS. And then this is what you will be using for your sort of mental roadmap while you're doing these cases. But IVUS co-registration makes the whole procedure a lot more streamlined. Now, can IVUS reduce contrast use? The small study shows a significant reduction in the use of contrast when IVUS is used. And this study shows that in patients who have IVUS-guided versus angiography-guided PCI in CKD stage 4, there's a significant reduction in not only contrast-induced nephropathy, but also patients requiring dialysis. This paper was mentioned before, Ziad Ali's paper, where he used no contrast at all in this group of around 30 patients. And this is a larger study of around just over 100 patients, about just over 100 lesions in over 80 patients, with quite a wide variety of patients, including left main, with some patients who underwent rotational atherectomy and some CTO cases, which shows actually that, it is feasible to do even fairly complex PCI in this group of patients. And this small study by Darius Dudek, about 20 patients, also shows feasibility. The important thing to mention in all of these studies is this is without the use of So when we perform co-registration, the cath lab, what's the setup that we have? First, you need good diagnostic images with good angles to show you the best views to be working in. And then we stick to them views for the procedure. As mentioned in the previous talk, when you're engaging the guide catheter, you look for a number of things. You might look for calcification of the left main stem. You may see pressure changes, particularly if the left main stem is tight. An injection of saline, you can look for changes in ECG, or if you think your guide's in the right position, you can gently probe with the wire. It's important to keep the same views that you're working in without any panning of the table. And this demonstrates wiring of the vessel with the roadmap that we have. Now, sometimes you may well need to give contrast, although you may set out with the intention you want to do this case giving absolute minimal contrast. We have to take safety into consideration. So the rule we use is if the patient has got any hemodynamic instability, any ECG changes that can't be explained by the part of the procedure that you are in, or if the patient is complaining of chest pain, which can't be explained, then we may well need to give a test shot and see what is going on. So this explains when we do the test shots as well as arrhythmias. Now, important things to remember when you're doing co-registration, you can only use the Eagle Eye catheter, which is a fairly bulky catheter, and it's a manual pullback. And so we have to manually pull back at approximately 1 millimeter a second with continual screening with no table movement while this is done. So you have your good quality angiogram from the past, and then on the day of the PCI, you've engaged the guide, you have wired the vessel using the previous roadmap, and then we're using this software, you will track the wire, and this will be the roadmap that we will use. And then this shows you how you do the co-registration. And then you pull your IVUS catheter back. This is a speeded up version. And then the software will automatically perform the co-registration. And then you can, using the software, track to see where your disease is and where you want to be starting and ending the stenting. So this is a low contrast case showing tracking on the wire. And we see the IVUS runs, and the yellow dots represent the picture seen on the right. So using this technology, you're able to find your proximal landing zone, your distal landing zone, your length of vessel that needs to be stented, and you're able to perform the PCI and do your IVUS run post. So on the IVUS run post, we see generally there's good stent expansion, but there is some areas where we can have further post dilatation. This will also show you if there's any proximal or distal dissection. It's going to show you stent expansion, and it will give you a lot of the information that you need to see whether or not you've got a good result there. So the next poll question is, do you really need an angiogram at the end? Or if you have all this information, can you not do the angiogram? And I think sort of this was answered in the previous talk. So I will come back to the answer shortly of the poll question. So is it possible to put everything together, the physiology and anatomy together? So this is a previous angiogram performed, and then we perform tri-registration on the wire. So on the IFR of this vessel is 0.83. And then we performing the virtual stenting. By stenting the proximal segment, you'll get 0.94. Going a bit more distal, you'll get 0.96. And you're able to perform a tri-registration. This gives you the physiology and the anatomy without contrast. And we see as we're tracking the wire, the yellow dots represent where you've got change in physiology and the corresponding picture scene of the cross-sectional IVUS. So it is possible to do anatomy and physiology and intervention, giving minimal contrast in patients who've got CKD. So how do we get the best out of the system? So first of all, the basics are important. Basics in terms of patient selection and basics in terms of judicious use of intracoronary imaging anyway. If you don't use much intracoronary imaging and then you switch to co-registration, you may struggle. So in a high volume intracoronary imaging operator certainly helps. And then it's really case selection. You don't want to be starting with the patients with distal left main disease, calcification, requiring rotational atherectomy. You want the more simple lesions really to be starting off with. But it's very useful to be learning the technique on just standard PCI cases. The more you use co-registration, the more you realize that this can be very beneficial in a wide variety of patients. And what we found is generally after using the Sync Vision system, you gradually realize that you can use far less contrast in standard PCI cases. So when you are faced with a high risk, ultra low contrast case, you've then got the skill set to be able to do this. Unfortunately, those, again, as previously mentioned, the patients with really, with CKD generally are going to have quite complex disease. And you'll find that these are not going to be the sort of patients that you want to be learning the techniques on. And it's important, once again, to remember safety. So although we have a target to do a case with very minimal contrast, we must take into consideration that we must not lose track of the fact that you want to get the patient out safely and avoid the resistance to think, well, their aim is to use absolute minimal contrast, because you will have to inject at times if there's any instability of the patient. Some tips: it is a bulky catheter, so you might struggle to do your IVUS run beforehand. You may well need pre-dilatation or preparation before you'll be able to get the pre-IVUS run. Generally, the system's quite accurate, but sometimes you might have some artifacts. So it is worth doing a co-reg error check. Often this is done by putting two wires in, and you check that where the bifurcation is corresponds with your co-registration on the IVUS. Doing a slow manual pullback, and we're in the practice of turning off our automatic injector or disconnecting the contrast syringe, because your fellow might be used to just testing after every sort of intervention that you've done. And finally, for the wider team, not to pan. So poll question 3, do you think there is a role for IVUS co-reg in your lab? And so this was our journey. We got the system in, and after getting the system in, we went through a period of training. And as with any new system, first of all, the sort of sad faces because of adversity to change. But once we started seeing the benefit of the system, we got the team engaged. The number of operators were very keen to use the system, and they were the ones who led on the project. And then amongst the cath lab team, we identified sort of super users who would also be leading. And together with the team, we were then able to take on these cases and really build a lot of enthusiasm within the whole cath lab. So when we're doing these low contrast cases, we've got a lot more interest. Also, getting the staff on the simulator training course helped. And as with anything, practice, practice, practice and drilling. The more you do these cases, the easier it becomes. So we find, when you're on a journey, you need to track your way down, and technology is something that certainly helps us using Sync Vision in these group of high-risk patients, and team work is really important. Thank you. Just before, can I just have the answers to the last 2 poll questions, please? Thank you.
Okay. Applause. Applause. Okay.
Thank you very much, Bilal, for giving us a wonderful lecture on the tips and tricks of using SyncVision for this very complex set of patients. I would like to open the floor for discussion. Any comments from our panelists, Donnie, Nick,
can
or
we see
Michael?
Them? Yes. Okay. I can't hear Nick yet. Okay, so
can you hear me now?
Yes.
Yes.
Yes, please go ahead, Nick.
Fantastic. Yeah. But again, as we've discussed here, our problem in the Philippines is that we don't have SyncVision yet. And as you were delivering your lecture, I was getting a lot of text messages from my colleagues here, sending me those sad faces, side emoticons, saying that how we wish we can have that soon. But as elegantly presented by Michael Lee, it's still possible to do an elegant case without SyncVision. However, the advantage of having SyncVision is that you really would tend to have probably shorter stents instead of having a missed target, because if you don't have SyncVision, your targets may be quite vague, and there's a tendency to use longer stents proximally and distally. So I guess it's still part of our wish list to have a SyncVision, but as demonstrated by Michael, it's still possible to do our part of achieving the learning curve by trying to minimize contrast even on non-CKD patients. And then as we do this, then we may have more skills to minimize contrast and eventually be able to use ultra low or zero contrast. But fantastic lecture, Bilal.
Thank you.
I would also like to echo Nick. We have SyncVision in our lab actually, but what I've shown you is sometimes we might not need SyncVision. Just like in Nick's lab, you don't have SyncVision, but you can still, depends on the position of the IVUS catheter to guide you for the accurate positioning of the stent. But of course, with SyncVision, you can have actually a better understanding what's the lesion behind and what's the minimum stent length that you need to cover a particular lesion. So that's how you can get around even without SyncVision. But it would be better to have the SyncVision in your lab.
But I particularly like the comments about, the more you do, the gradually you actually build that into your part of your habits to start gradually cutting back on your contrast. And it doesn't have to be your CKD patient, because those are the toughest patients that we encounter in the lab, as both speakers mentioned earlier from Michael and Bilal, right? But actually, in your day-to-day practice, you can start putting this into practice, building this into your routine, and gradually, when you eventually face those patients, it becomes more of a second nature, and your team that was emphasized so many times again can be a lot more slick when it comes to doing it.
Can I have a question?
Donnie.
Okay, great. So nice lecture, Dr. Patel. So in my hospital, we just have a co-registration system, I think around 4 or 5 months, and then we still learning how to do it every day. So one of your lecture, is new to me, that you can do a roadmap before you're doing registration by just put a wire, because Philips guy came to us and then mentioned that before you do co-registration, you must perform angio with contrast and then do that as a roadmap. So can we do just put a wire, and then which is better, doing contrast or doing just wire inside?
So the standard co-registration is done on the angiogram. So they say take an angiogram, and then the software will often automatically mark it when you mark the 3 points. But if we want to do a low contrast case, then you do the angiogram just with the wire in, and then manually you will mark out the wire. So the software will use that to co-register against. So, you can co-register on the wire in the same way that you co-register on the angiogram. But then you don't need to do the angiogram with dye. You just do the angiogram with the wire down the vessel.
All right. Okay. Thank you.
So Bilal, I think this topic has been covered in a lot of webinars, but sometimes some people aim for the perfection where you have zero contrast. But I think for safety reasons, I think we still need to have some diagnostic shots at the end. What's your take on that?
I fully agree with you there. I've seen Ziad Ali's work where there's no contrast given at all. They do an echo before and an echo afterwards. Personally, I quite like the term of the leading shots, because you've done a very complex case on a very complex patient. We're balancing risk and benefit. I mean, the question I ask myself in these cases is, by giving a single shot in a biplane lab, which we have, which will give a lot of information, really, how much harm is that going to do to the patient when I've hardly used any contrast in the case, versus not doing that shot and then finding out afterwards that, you may have caused some complication. Because in these very complex cases, our focus might be on the distal left main stem, and you might find your LAD wire might have poked out and caused a little distal perforation somewhere. And so my practice is doing that final shot at the end, although throughout the cases, we do try and absolutely minimize.
Thank you.
So perhaps it's, with some of the discussion that we already brought up, and, two absolutely brilliant lectures and good discussions, maybe we can share a case that we performed recently in Singapore. We have prepared a live in a box case. So can we actually now bring on the case to share with you? I'm also obviously very grateful to Sujin, who helped me spend a lot of time editing this video. So can we play this? The elderly lady who is non-smoker. Oops.
Can we go back to the first slide and pause it?
A bit too fast. Okay, so as an elderly lady with history of hypertension and chronic anemia, EGFR 36, okay, came in with NSTEMI. EF is preserved. This is the RCA, and this is where we're gonna, be tackling the right coronary artery.
It's a very critical disease in the mid-RCA.
Yeah.
Is this done as an ad hoc or stage, Paul?
As a stage. Okay, this is the left coronary artery. Because of the ECG change, my impression was the left coronary artery is probably the culprit. And left coronary artery was complex, so it took a little bit of time to get that fixed. But because the RCA is also very critical, and the fact that there was no particular kidney injury after the first procedure, so 3 days later, we staged the RCA PCI.
Is 3 days an ideal stage interval for someone with CKD, Paul?
Yeah, I think, happy to take questions, but there was no creatinine change after the first procedure. How many of us will leave? Maybe the answer is, the question is how comfortable are we to leave that really critical RCA alone and wait for, 1 week, 1 month before we do it. But at that time, I think our discussion was we're just going to get on and do it, right?
Yeah.
The point I just wanted to bring up was that CIN post-contrast, the maximum creatinine rise, sometimes it's just 3 days to a week. So you'll be worried that in the first 2 days post PCI, there's no rise. Doesn't mean they'll not take a hit subsequently. So I mean, just that point. I do recognize in multivessel disease, sometimes what you think is a culprit may not be the true culprit. So
yeah. And I think, Jack, you probably have already given the game away a little bit too.
Really? Okay, sorry.
So I think the patient was done on a Friday, and we did the stage PCI on a Monday.
Yeah, correct. And she's happened to be the mother of one of my fellow consultants as well. And so the plan was to do ultra low contrast PCI to the right coronary artery. Okay. Can carry on with the video?
So Paul, when you say ultra low, you mean how many mils of contrast are you?
Well, we are aiming to get to the EGFR 36, so I'm hoping to keep it at 36 or below. That would be my plan. So, EGFR 1:1 ratio.
And just for the audience, someone normal EF, elderly, EGFR 36, do you really follow the Poseidon type of hydration regime in your lab?
Do we? I think we actually.
I think that means you're referring to the measurement of LVEDP.
And then
so I think for me, I don't do it all the time. I think, but some of my other colleagues may measure the LVEDP and then they will titrate the hydration according to the measured LVEDP.
Yeah. And Michael is still online, right? So maybe we can ask Michael whether he does that.
Well, we sometimes will do it, not always, not for every single case. But sometimes we will follow that protocol because we find that protocol is most reasonable to follow, and most of our patients with this protocol usually will end up with not much acute kidney injury.
All the time?
Not all the time, just for selected cases, really high risk cases with really impaired renal function.
Okay.
So can we carry on the case? So this LAD was fixed with 2 stents, and this is the planned stage PCI to the RCA. Next, please.
So the risk of CIN for her was calculated to be about 26% and risk of dialysis about 1%. Huh?
So we are now engaging, this is a transradial approach. Okay, we're trying to engage the right coronary artery. We had the previous angiogram on the screen, so we know where it is. So we managed to engage and wire the vessel quite easily. So no contrast at this point.
Oh, just out of curiosity, what CKD stage should you not do a transradial approach?
Actually, I don't.
You don't.
I don't think that concern me.
Okay.
The only time that I have struggled with the fistulus.
Pause. Yeah. So as you can see that the patient had a very critical mid RCA lesion, so you have to pre-dilate the critical lesion before you perform the IVUS. So that's what happened. We dilate the mid RCA lesion with a 2.5/15, and then after that we did the IVUS pullback.
Okay. So can we carry on? So 2.5/15 pre-dilatation. And I took a picture. Can I just pause? Maybe this answers the question that, and also, showed what Bilal mentioned early on. This is just a wire in the RCA, and we can use this as a roadmap for the IVUS co-registration. Donnie, you asked this question early on, right? Okay.
Yes.
Can we carry on?
So the wire acts as a surrogate for the vessel, so you can do the tracing, the dynamic roadmap without injecting any contrast.
So I missed that. So far, no contrast.
No contrast.
Okay.
So you can see the IVUS going in very nicely.
Mm-hmm.
So it's the volcano eagle eye with the dots.
We're now recording. And you can see the mid lesions coming up around about there, which is obviously tight. And then there's also one more lesion in the proximal RCA, which is coming up there.
So with the once we do the IVUS co-registration, I think important thing is to identify the landing zones.
So Donnie, you see this is what is happening. So the system already mapped up, so you can actually manually adjust it a little bit if you're not happy with how the computer AI traced out the vessel. It's actually reasonably easy and straightforward to do. Once we're happy, then you can use that as a co-registration. I'm going to pause here for a second.
Pause. Yeah.
So while we're focusing on getting the co-registration, analyzing where the lesion should be and what size stands with our reference diameter, etc., patient started getting a little bit unwell. Okay, I'm going to let this play a little bit, but you can probably already see some ST elevation and the heart rate also have dropped. You notice the heart rate is now dropped to well below 100. So therefore, at this point, I
Just
gave
pause.
some contrast.
Pause.
Just pause there now. So I gave some contrast. And I'm actually quite pleased to see that the flow is still okay. I'm going to invite some comments at this stage to maybe Jack. Have you seen anything that, you know, I should be more concerned about, and happy to hear from the panelists whether you've seen anything that bothers you.
So sometimes I saw that outer predilatation with the IVUS is TIMI-3 flow. It looks pretty decent actually.
Yeah.
What you show in IVUS.
Yeah.
But sometimes it could be because there's no contrast. There was a proximal right lesion. The guider could have been engaged there, causing the either no flow or slower flow, and transient ST elevation. The moment the guider comes off, I think it looks like it's back to TIMI-3 flow. That could be one of the reasons, but otherwise it looks pretty decent actually so far.
There was no pressure damping at all throughout this case. And I'll show you the IVUS of the proximal lesion later on. But I suspect actually this lesion is hot. Okay, while we think the LAD was the culprit, I think the RCA was not still free either. So as soon as the post-dilatation happened, and with the IVUS being a little bit occlusive, started getting quite shirty. Yeah.
Just like to ask the rest of the panel, is this when you inject some contrast at all as well, like what Paul did?
I think although we target at ultra low contrast, this is the time that I will probably use a few cc of contrast and try to see what's happening. And I agree with Paul that even from the IVUS, you can see that it looks a vulnerable plaque to me at that particular BRCA critical stenosis. So once you do pre-dilatation, shower emboli down, causing sort of a slow flow, and then actually it gets better with time. And then when you do the angiogram, actually the flow comes. I think that's probably what's happened in this particular case.
So I think the message is quite clear, although it's a focus on ultra low, but the main focus is still patient safety. I think we all probably agree on that.
Absolutely. Absolutely. Okay. So can we continue with the case, please? But after this injection, I was quite pleased that, you know, the flow is still okay, and distal vessel seems okay. You can see that there was a proximal lesion. So we carry on with the analysis, looking at the distal reference. There was a question asked by one of the participants about how you decide on the distal, where your distal landing zone. So we use the same vision. We base on IVUS, okay, and find out where the distal landing zone is. And on the co-registration, we also estimate the stent length to be 46 mm based on the pullback.
So purely normal to normal segment.
Correct.
Right.
Yeah.
Although initially the culprit lesion looks much shorter.
Correct.
Yeah.
Yeah.
Will you attempt a spot stenting here?
Okay. Can we just pause it?
Yeah.
Can we just pause it here?
Is that a reasonable approach?
Yeah. I know it's a really good point. But I think the beauty of IVUS, of course, is you actually able to know that your stent will end up in not end up in a heavy blood burden area. So if it's purely based on angiogram, you might be just saying, well, maybe 38 will be enough. But with IVUS, you can clearly choose a very nice landing zone. You can see on the maybe here the image showing the area of the proximal lesion. Area 1, right? So
Paul, you might actually see some more elevation of the center.
Yeah.
That is what happened.
Michael, you're so clever.
Yeah, because I was just coming back to the spot stenting bit, because you already had the balloon dilatation with slow flow. And if you're going for a long segment, large, I would say adequately sized stent, but you have to be probably mentally prepared for the complications thereof.
Yeah. Correct.
Yeah, spot stenting in this patient may be a bit tricky sometimes, because sometimes, you know, if patient breathe and move, then you miss it, you see. So I think I will go for a longer stent. Yeah.
Bilal, what would you have done based on the IVUS, normal to normal 48 mm, or go for spot stenting?
I would go for the longer stents as well here.
Okay. So can we carry on the case? This is a 35 by 48 mm stent deployed at high pressure.
Usually high pressure is how many atmospheres here?
16
okay.
to 18. And then we did the IVUS again.
I think it's showing that the stent is well opposed and expanded from the pullback. There was a proximal lesion.
There is a lesion there, right? The proximal lesion, you saw that. Okay, I'm going to pause here. Now, there is a bit of disclaimer because, you know, this is a live in the box. So we have cut out and edited out some of it. So Michael was absolutely right because as soon as the stent's gone in, okay, all the ST's gone haywire and the blood pressure dropped again. So took me a while to get the flow back. I actually have to put quite a bit of adenosine very distally. So I put a aspiration catheter, but instead of aspirating, I put the aspiration catheter distal to the stent and injected some adenosine downstream. I even give a very small dose of adrenaline downstream to restore all the blood flow. And then the IVUS showed that the stent is still undersized. So it took me a long time and waited for the flow to normalize before I plucked up enough courage to gone back in with a 4.0 balloon to post-dilate the stent up. And lo and behold, of course, after the 4.0 post-dilatation, the flow, of course, has predictably gone down again. And then I gradually managed to get it back. Okay. And at that point, then the fellow said, what about the proximal RCA? Okay, so what do you think of the proximal RCA? Can we just play? Of course, the time is whatever is left behind, I would just join one more stent to go to the ostium, the RCA.
So angiographically, maybe about 40–50%, but there was no pressure damping, right, Paul?
No.
I think we have a poll question on that.
So yeah, you see the post-dilatation. But between that and the post-dilatation, there was already one episode of no reflow. It took me quite a while to get out.
What is your usual cocktail for the right?
And let's just pause here. This is a nice picture because in doing ultra low contrast, positioning the post-dilatation balloon within the stent is also very, very useful. And in some of the lab, in our lab is getting a bit elderly. The imaging quality is not great. But with the SyncVision, this is the Angio+. You can actually see the balloon within the stent highlighted very clearly. So you're actually quite confident that when you post-dilate, you are within the stent. You can see that here, right? Okay, just can we carry on playing? Okay, so you can see the proximal lesion quite clearly now. So what's your thought? We actually went ahead and did a IFR on that. And this is the IFR of the RCA at the end. So I think we have a poll question, right?
Yeah, can we have the second poll question?
Can we come up with the second poll question?
Sorry, Paul, I missed the IFR reading. What was it?
0.98, right? 0.98 or 0.99. Okay. So would you be comfortable? I mean, obviously a lot of talk about, post PCI FFR on IFR. So this is the first polling question for our patient. How will you treat the proximal RCA lesion? You will treat it medically based on angiographic findings that we thought is about 50%, or we treat it medically based on IVUS findings and perform the post PCI FFR, IFR for decision making. Can I just see how you would practice in your lab? Okay. Well, 50-50. Maybe just 2 people voting. But no one treat based on IVUS findings. That's interesting.
I would.
Yeah. Okay. So.
I will use the 3.
You will base on.
what's the IFAS finding on the area of that particular?
The MLA is above 8.
Yeah.
Above 8. So adequate MLA, IFR 199, angiographically moderate disease, I will probably leave it alone.
Yeah. And also, I know that on IVAS, I did cover from normal to normal. So what I left behind, I have not touched. But largely because my courage ran out at that point. Okay, so we see that most of us will build on FFR and IFR. Any comments on using FFR or IFR for decision making in this particular case? Because there was 2 episodes of no reflow. Is there some concern about the microvascular resistance might have, given us a sort of false negative findings?
I would have some concerns, Paul, with after episode of no reflow.
Yeah.
I tend not to pull out another equipment because it's also chargeable. And I agree with Michael, I probably base it on the IVAS and the fact that it's TIMI3 flow. As long as there's no dissection there, probably it's good enough for me to leave it alone. Okay. The MLA noted is above 8 now.
Yeah. Can we bring back our panelists to join us? Okay, any comments about the case?
Okay, Paul, I'll give my comment.
Go for it.
Okay. Well, during your initial angiogram, at that point that there was infection, the proximal RCA did not look so bad, but it looked worse, or actually it looked ugly after the stent deployment. So could this be like something like a visual deception, like because you improved the mid segment and then the proximal now looks bad? And number 2, the IFR numbers are quite high to doubt whether this is just false negative. Okay. So what do you think about the optical illusion that could have probably happened?
There's certainly certainly an element of that. You make somewhere pretty and then the other one looks less nice anymore. But certainly, and there's obviously with what's going on there probably an element of spasm as well. Yeah. Good point, Nick. Very good point.
How about IFR?
Yeah. So maybe Donnie, what do you think? IFFR versus IFR. I didn't bother to do the FFR here, although I have plenty of adenosine with me at the point.
Yeah. Well, in my lab, of course, we tend to use IFR because all my nurses, all my fellow love it because we don't need time. But in this particular case, maybe I will think about to measure IMR, maybe because you mentioned that there's some episodes of the distal emboli, but I'm not really sure. But in my lab, I will use IFR to make my decisions. Even we know that there's some episode of the distal thrombus, but hopefully it's not as severe as if we're dealing with STEMI. Unfortunately, we didn't see all pictures of your struggling with the thrombus, but in this particular case, I will usually in my lab we rely on the IFR results.
Yeah. I think some of the this case, we discussed whether we want to show this case because it's not exactly one of those proud, ultra low, no contrast, image guided PCI. But I thought actually brought up quite a lot of points to discuss here, especially when we encounter some difficulty. I mean, final contrast dose is about 50. And I can see quite a lot of questions being asked here is what is the maximum limit of contrast used? How many is maximum limit? So the actual amount and volume of contrast has been brought up quite a few times. So as a rough guide, I think most of us would use 1 mils, 1-to-1 as to based on the EGFR of the patient. But once your patient is hemodynamically compromised, once the safety is an issue, I think most of the cardiologists will save the heart first and worry about the kidney later. But, right. I think, Pilar, you have written on that subject, you have lectured on that subject quite a lot. Just keen to hear what your thoughts about this case.
Yeah, I mean, I think it's a really great demonstration of some of the challenges you come across. So you start off with a mindset of you're going to use very little contrast in a case like yours. And then the time comes where you've got that first ST elevation that you're going to have to do protocol deviation and give some contrast. And then when you're going down sort of unstable, no reflow, then you'll still try and minimize, but then that mindset of this is like an ultra low stroke zero contrast case has to go to make sure that you get the patient out without any adverse event. So I think it's a really good demonstration of when, I say, we like showing these cases that are brilliant without any problems and without any contrast, but it shows where you should give contrast, where you have to have that balance and wisdom really in the cath lab. Just a couple of points about what to do with the proximal lesion. I think if you didn't have no reflow there, I would have been tempted to deal with it. There's a large plaque burden, although I think I agree with you. The MLA was not significant. The IFR, because there was quite marked no reflow there. I'm sure there will be microvascular dysfunction. So I don't know how much you can rely on that, but it's unlikely the lesion in and of itself would have been hemodynamically significant. So my rationale probably would have been sort of oculo-IVUS reflex, I think, and hard to justify based on evidence.
Okay. Yeah.
Or
yes,
well, one
Nick.
concern that I have about trying to minimize contrast, it's that sometimes there's a tendency to miss small perforations distally because you're trying to save on contrast. Did it ever occur to you that you may possibly be dealing with perforation in this situation?
Sorry, Nick, you
missed the wire perforation.
Yeah,
I think could have been missed. That's the
because you're minimizing contrast.
Yeah, I think there was also a point that was brought up early on. I think a final angiogram is useful to look into that, and especially, you want to maximize everything. So I would normally, not go to maximum X-ray magnification, but drop down 1 mag so that you can see the whole peripheral site, and 1 long injections to make sure you don't miss that. But if one is really gunning for zero contrast, because not necessarily because renal, or more because of contrast hypersensitivity, you really don't want to use contrast at all, then what Syed Ali said was do an echo before the procedure and do an echo after and do another echo before you discharge to make sure you don't see anything. So I suppose that's also the workaround way. So I think, if it's okay, we are really running according to schedule, which is really nice. Doesn't happen every time like this. So maybe I think we can call on our final lecture, because Pilau, have you got another lecture to share with us? Some really eye-opening complex case. We saw a stunning case from Michael early on, but Pilau, I think the table is yours for you to highlight some of the more challenging case.
Thank you. So we've talked a lot this afternoon about why we do things, different ways of doing it, and how these patients generally have got quite complex disease. So I've got a selection of cases from our centre of sort of high-risk cases, and the title is Driving into Darkness with Light at the End of the Tunnel. And we've sort of grown up with the angiogram, and we base our intervention based on what we see on the angiogram and the dye in the vessel. And moving towards not injecting dye or very little dye, or performing it without contrast, is a sort of big sort of change, and can be quite sort of worrying and challenging. And in a way, it's like you're there driving on the highway, and you basically, someone's turned your headlights off, and it can feel like that when you're starting off. You definitely don't want to end up like this. And so it's important getting the balance right with learning the technique and using the technology, and to get the best outcome. But we know for the patient, with CKD, they've got complex disease. Often you need to use things like rotational atherectomy. Often there might be left main bifurcation. So, is it possible to deal with the very sort of complex case set and turn the lights off, and not end up with a car crash at the end of the day. And we're going to, show some cases demonstrating this. So the first case is a 64-year-old gentleman that came with an anterior ST elevation myocardial infarction that had his LAD stented. Left ventricle was severely impaired. Predominantly the LAD territory was down, and he had significant bystander right coronary artery disease with this EGFR of 21. This was his right coronary artery. You can see this heavily calcified stenosis in the mid-right coronary artery and further disease seen in the PLV branch. So we brought him in to deal with the right coronary artery a few days afterwards, and he was brought in 5 days after the anterior MI. And again, similar to the previous case, the question was, are we comfortable leaving this when he's already had a large anterior territory infarct? And we did this using minimal contrast. So the vessel is wired without contrast. A turnpike spiral is used, and we then switch over to floppy rotor wire, and we perform rotational atherectomy. And after rotational atherectomy, we do 2 co-reg runs. So this is a case where we did an IVUS up front, again, because of heavy calcification. Other concerns in these sort of cases is that because of the bulky IVUS catheter, it may cause significant ischemia, especially if you get it stuck in the lesion. So preparing the vessel first may be mandated. So here we did 2 co-registered runs. We did a cranial run first to look at the distal vessel. And then we actually did 3 runs. We looked at the very distal vessel first, the PLV. Then we looked at the right coronary artery just around the angle of the heart. And this is the co-registered run coming now. So the white marker is where the is tracking the wire. And here you see sort of calcification coming around the bend. And then we did a second run, sort of looking at the sort of mid and proximal vessel. And here you'll see this big lump of calcium coming in with some disruption there. And as you come up more proximal, you'll still see areas of some concentric calcification, or the minimal luminal area is not bad just around here. So then, we know this is quite a large vessel, and we decide to just do a drug-eluting balloon in the PLV branch and then stent the proximal and mid vessel. With preparation, we find that there's still wasting of the balloon seen in the proximal vessel, which is treated with a scoring balloon. And then we put 2 large drug-eluting stents in, post-dilate, and this is the IVUS pictures afterwards with co-registration. And then just a single angiogram is done with 3 mils of contrast, and that was the result. And the patient went home. He's been followed up. He had no deterioration in renal function, and is doing well. So this was the second case, and the second case is an 80-year-old chap with CCS class 3 angina on multiple anti-anginal drugs with a mild impaired LVSD and CKD stage 4. His EGFR was 18. This is the angiogram that was performed in a neighboring hospital, and you can see a very severe pattern of disease. There's some involvement of the distal left main stem, LAD, proximal and distal circumflex. And looking at this left main stem in a little bit more detail, you see this quite nasty looking appearance of osteostenosis and ulceration and a further sort of tight stenosis just before the distal bifurcation. So this chap was referred for surgery. He was turned down for surgery. We often find this is one of the greatest reasons for surgical turndowns is CKD. He's got this pattern of quite severe disease with significant renal impairment. So, this is where we sort of end up navigating in darkness, and we say, is this a case for using ultra low contrast PCI? So the decision was made to take him and do ultra low contrast PCI. So this is a poll for the audience. Now, if we imagine that this patient did not have CKD, to deal with the left main stem, LAD, circumflex, on average, how much contrast, would the people in the audience use here? And I will come back to that question the answer to that question when I show the end of this case. So this is a case of left main and multivessel disease. So we engage the guide. So this is the actual tracing on engaging the guide. We see these changes in pressure, and we then have our road maps up and quite quickly wire the vessel. And we wire the LAD and we wire the circumflex, and we have our protocol. We're only going to inject if there's chest pain, hemodynamic instability, ECG changes, and we predilate the left main stem. And then we perform our IVUS co-reg run. The co-registration is performed on the wire, and then we see quite nicely a good distal landing zone, the proximal landing zone, the length of stent that's going to be required, and we prepare the vessel and place 2 drug-eluting stents and post-dilate, and we do the IVUS afterwards that shows good stent expansion. So in this case, we decided to leave the ostium of the LAD because there was no disease seen at the ostium of the LAD on the IVUS run. Now we turn our attention to this, the large circumflex system. This is a speeded up run. See, there's quite significant disease seen at the second OM branch, and this ulceration seen in the proximal circumflex just before you get to the left main, and there's ulceration seen in the left main. Bearing in mind, you've got these 2 sort of side branches here. So the decision, if you're going to do this using minimal contrast, then are you going to go down the route of bifurcation strategy here? Or are you going to put multiple stents in? Or is there anything alternative that we could do? Based upon this, we decided to do a drug-eluting balloon in the distal vessel, really to avoid stenting across these 2 side branches. And now you have the problem of how do you deal with the left main stem and deal with this. So we know the IVUS shows there's no disease at the ostium of the LAD. So we decided to do a provisional stenting strategy from left main stem into circumflex. And then the question is, how do you stent the ostium of the left main stem without giving contrast? So we use this technique with the floating wire technique, a wire in the aortic root, and then you use that to guide where the ostium of the left main stem is. We stent the left main stem to circumflex. We then perform a pot with the 5.0 non-compliant balloon. We've rewired and opened the side struts to the LAD and perform a final pot. And this is the IVUS from the LAD to left main stem, showing good stent expansion. And there's the ostium. You see the struts open where the circumflex origin is, and you see that there's no problem at the ostium of the LAD. And that is the origin of the LAD seen on the IVUS with a red star. And that's the left main stem. So, and these are the post pictures IVUS of the circumflex. So we start off with this and we end with a 0. So this is the only shot done in the whole case, is a single shot for a biplane angiogram. And 5 mils of contrast was used for this case. The patient's been followed up and has been free of angina since, and there was no deterioration in renal function. You just go back to the poll question for the audience about how much dye, in this sort of case, we would normally use. Now, I know, for myself, if I'm not going in with a very low contrast mindset, in a case like this, you'd quite easily use over 100 mils of contrast. Is there any chance we can put the poll answer back up? So the next case is an 80-year-old gentleman with hypertension, CKD stage 4, EGFR of 17, severe peripheral vascular disease with previous surgery. He's presented with an NSTEMI with severe widespread ischemia on the ECG that was not settling down despite medical treatment. Now, this was a gentleman that was seen by several members of the medical team, and because of the comorbidities, initially he wasn't referred for cardiac intervention. Despite ongoing symptoms, he then came down to the cath lab for an angiogram. And these are all the sort of comorbidities that were concerning, and his LV was moderate to severely impaired. So this was the angiogram that was performed. And the angiogram was performed just using 13 mils of contrast. So we've got the we have a biplane lab which helps us in these type of cases. And then you have this appearance of the distal left main stem, which is heavily calcified. So again, you're dealing with this situation with CKD, poor left ventricular function, peripheral vascular disease, Heart team discussion. He's not a surgical candidate. So he was referred for consideration of ultra low contrast PCI. So now, you know, we go from, instead of driving on a nice tarmac road, you're sort of on the back of a mountain on a track like this, and somebody's turned the lights off. So poll question, the next poll question is, what access site would you use? Would you use hemodynamic support here, use of calcium modification, or would you go for a provisional strategy or a 2-stent strategy? So I'll just let you answer that while we go to the next. So this was the strategy that we used. We went for a 7 French radial approach. We didn't use balloon pump or impeller because of the severe peripheral vascular disease. We decided up front this was going to be a 2-consultant case with upfront 2-stent strategy. And so this is a high-risk case in someone with impaired left ventricular function. I've described the cath lab setup before. And then the guide is engaged. We can see the calcification of the left main stem, and then we wire the circumflex. And this is a spider view using this roadmap angiogram from before. And then the LAD is wired. And after wiring both the LAD and the circumflex, we then switch over to a cranial view and dilate the left main stem first. Then we go with a 1.75 millimeter rotor burr. There's quite heavy calcification at the distal left main stem. Then we perform our IVUS run in the LAD. And this shows a good landing zone. It shows the length of vessel that's going to be needed. And are we going to need any further calcium modification as well? And you see that there is an arc of calcium there, but it's just over 180 degrees. And you see some disruption of the calcium at the distal left main stem. And there's the left main stem. We do an IVUS of the circumflex, and this confirms that this is going to have to be an upfront 2-stent strategy. And in case we thought sometimes after rotablation, it might change the anatomy, but this is going to be an upfront 2-stent. So we decide to go for a DK crush strategy. First, we stent the mid-LAD, and then we do our first step of the DK crush. So we position the circumflex stent with just a few millimeters in the left main stem with a balloon in the LAD, and we deploy the circumflex stent and then crush with a 4-hole balloon in the prox LAD left main stem. We then rewire, and this is rewiring of the circumflex. And again, you know, with the software and the sync vision, just taking a short cine run, you can see the struts quite well. After rewiring, we then open the struts of the circumflex and do the first kiss using 3.5 millimeter balloon in the circumflex and a 4-hole balloon in the LAD. Now, the question is, how do you stent the left main stem back to the ostium without contrast? Again, we use the floating wire technique. Then you have your pots with a 5-hole balloon. Important to keep the pot not a distal pot because it will deform the carina. We rewire circumflex, and you have your second kiss. And the second kiss was performed with 2 4-hole balloons, and then you have the final pot. This is the final IVUS run, circumflex to left main, and you're going to see the LAD coming in there at 2 o'clock, and you see nice clearance of the struts. And this is LAD coming back to left main with coming in at 4 o'clock. You will see the circumflex with a wire coming through there. So you've got nice clearance of the struts there for the origin of the circumflex and the origin of the LAD. We've got our single shots at the end. And the whole procedure was performed just using 4 mils contrast in a biplane lab. So this was this gentleman's echocardiogram before seen at the top and after at the bottom, and done 4 months afterwards. You see the significant improvement in his left ventricular function, and he's doing very well. So what about, you know, is there any role for this technology in the CTO patient? So this is a patient who's got an indication for intervention on medical therapy, very symptomatic with angina. And we see that there's a CTO of the right coronary artery. Now, we have wired this vessel and then performed the run. So this was wired using a fielder wire and then a pilot wire, and then we switched over back to a standard angioplasty wire. And on the IVUS run, I'm just going to go back to this run here. So normally you need dual injections to see where your wire is. There was concerns here that we might have gone out of true lumen into false lumen, back into true lumen. And normally you do your retrograde injections to see where your distal landing zone is going to be or what's going on. But, you know, the co-registration can be used, again, co-registering on the wire to see where your distal landing zone is going to be and what's going on with the anatomy. So I'm going to just start this run off here. And you see in the distal vessel that you're in false lumen there. And now it's going to come back into true lumen and there. And there's a lot of atheroma. So this determines where our distal landing zone is going to be. And then we can use this without giving the retrograde injections to determine your distal landing zone. So there is a role for it in CTOs as well. And this was the run after stenting, showing that you've got good stent expansion. And this was the angiogram performed at the end. So is it reproducible? So, you know, in our center, we've got a quite complex set of patients which have had left main intervention, and a lot of these have been left main bifurcation. So this is a patient with tight distal left main, quite frail surgical turn down, and this was dealt with a scoring balloon, and we had to use intra-aortic balloon pump up front, and we see this was stented with a provisional strategy, and you see the IVUS pictures on the right. This is another case of distal left main performed with DK crush, using just 5 mils of contrast. And then this was a really quite challenging case here that we had with the patient with gross ischemia whilst put on the cath lab table before we'd even put a sheath into the patient. An intra-aortic balloon pump was put in up front, and you see in the panel C that there was gross ischemia. After the balloon pump went in, the ischemia improved significantly, and then we were able to deal with this patient again with a dedicated 2-stent DK crush strategy with a good result, seeing the IVUS of the distal left main stem in panels F and H with good clearance of the struts. And again, this case was performed with 6 mils of contrast in total. So it's important what the target is. You know, is the target to use the minimal amount of contrast? Really, the target is to get your patient out of the cath lab with an excellent result using intracoronary imaging and the tools that we have, using the minimal amount of contrast safely. It's not a question of how low can you go. It's a question of overall result, balance between safety and outcome. You know, and when we're sort of driving in these conditions, it's nice just to turn the headlights back on and see exactly where you're going. But we can do this with the technology that we have, with the teams that we have on board. So in conclusion, and road to ablation, it allows us to offer intervention to the highest risk of patients with a lower risk of contrast-induced nephropathy. It is a very much team-based approach. We've got a team of consultants with an interest here who work together to deal with these patients. And it's really making the best use of technology with the team that you have. Thank you.
Thanks, Bilal. That was an amazing series of cases, reinforcing and following up to Michael's amazing case as well. Any questions from the panel for Bilal for this series of cases?
Well, this is Nick. First of all, Bilal, I felt like joining the group who gave you that very warm round of applause. Your case is very fantastic and highly educational. Anyway, one practical question, because when we do ostial left main, we usually would take a cranial view or a left cranial view to be able to know exactly where we're landing. If you use the floating wire technique, do you use the same views as well?
Yeah, yes, we do use the same views as well. So generally, I use sort of LA or cranial view for this technique. There is there's a nice paper demonstrating the outcomes of this technique. So I think one of the concerns people have is, well, you're stenting the ostium of the left main stem here, and is it wise to do this without any contrast? And again, it goes back down to the safety issue of when, if you want to give a small test to check where you are here, by all means, go ahead and do that. But we've also got the benefit of IVUS to show us, the result that you've got. What you don't want here is the stent hanging out a lot, and at the same time, you don't want to miss the ostium. And I think this, we've had pretty good results with this. Professor Lee, I saw that in your case, it appeared as though you used a similar technique when you did your case, the chap that needed the TAVI.
That's right. We use actually 3 wires, 1 pigtail, and then 2 more wires to just outline the structure of the aortic cup, as just in your floating wire technique. So you can actually document the position of the cups, and then for you to position the left main stem quite precisely.
Donnie, any comments?
Yes, I enjoy your cases, Dr. Bilal. So I really like your approach to the second case here. You put in a DEB instead of DES because you're not sure whether you're dealing with the bifurcation. So you just a simpler technique. Even we know that the RCT regarding the EB in CKD, I think, is not really well known. But I like this idea. But the thing is that you mentioned there's also some calcification in the part of you put a DEB. Maybe you can easily create a dissection as well if you put when you dilate the DEB. So maybe DES will be the backup for this strategy. Is it right?
Absolutely, yes. And I think you always need a plan B. And I think in a case like that, we're trying to balance severe multivessel disease. You want to use very small amount of contrast, and it's balancing the 2 things up here. And had we ended up with a problem there, the bailout would have been you would have had to go and stent that with a DES.
Michael,
right,
do you have any comments on the cases?
Yeah, a lot. For discussion's sake, you've shown us beautifully that you can almost do anything without contrast. Rotablator, all the arthroplectomy devices, complex stenting. Sometimes, when we really want to use OCT or OFDI, is it possible with this sort of ultra low contrast or no contrast, even that we are still able to use OCT or OFDI? Because for some particular cases, like in my case, we want to do single string cool-off, but we want to make sure it is really the furthest string that we cross. OCT or OFDI actually gave us a better result, better image. So is it possible? No contrast or low
I haven't done it. And I've discussed, I think Ziad Ali's got a big interest in sort of zero contrast OCT. He has shown some cases using saline, and there's recently, been a bit of talk about that as well. People have used Dextran as well for OCT. And I know that there is talk of a new agent being developed that is, not going to be nephrotoxic for specifically for OCT. But I haven't used it, and I think with saline, I was told that you may need to change some settings on the OCT machine, but I don't know. But I know Ziad definitely has got a lot of experience in that field.
But great question for Michael.
Dextran, but we have been using saline to do OCT, and it gave actually pretty good images. But you need a large amount of saline to really get a good flush. But I think Dextran would be a very good alternative.
So the part of Dextran, Paul, you have something to comment on use of Dextran?
We use Dextran a while, and the viscosity is similar to contrast, so it does clear the blood pool very well in OCT. But the concern, of course, is that Dextran is also can be nephrotoxic, and there were case reports. In fact, one of our last APEC-I webinar, we did touch on that topic, and some of you were also our panelists as well. I think using the normal saline RCA worked really well. Maybe in the left coronary artery system, it can still be improved a little bit.
I also would be a bit more hesitant in using it in the osteo type lesion stenting location for OCT.
Yes.
So I think in general, the general rule is probably IVUS, Michael.
Yeah.
In
Maybe
this case,
IVUS for LCA and RCA using
Saline,
RCT.
Maybe a mix of that. Yeah. Back to you, Paul. Yeah.
No, I think, maybe we'll come to a stage in which, we already gone through why we need to do this. We've seen the logic behind it. We've seen some fantastic cases, how it's done. And you saw a case that wasn't particularly successful, but how we bailed out of it. I think it's pretty comprehensive. I just want to maybe at this stage ask each one of you any comments or any pearl of wisdom that you want to share with our audience. Maybe I will start with Michael, you first. Any comments or advice for us to take home?
Right. I think CKD is a particular group of patients that we would anticipate a lot more complications when we do PCI because of the complexity and the comorbidities of these sort of patients. So when we come to the PCI procedure itself, I think adequate hydration and then really, really minimal contrast or contrast-free will be the key for this sort of patients' PCI. But bear in mind that we always have to balance the risk and the benefit of low contrast.
Well, maybe I'll move to Nick.
We really need to do angio.
Yep, great. Thank you, Michael. Nick, any comments?
Yeah, we have emphasized the need for team approach here. And what we did not discuss was how many people are involved in the team. Do we need like an IVUS specialist to be doing the case with us? Do we need a colleague always partnering with us when we do things like this, like when we do CTOs? Or do we assign a radiology technologist to be our IVUS eye, perhaps? Can we briefly answer this? What is the team made up of?
Maybe those questions, maybe I could conveniently push it towards Bilal and team approach. Do you need an IVUS specialist? Do you need a second operator? I mean, what's your thoughts?
Yeah, so our approach is that these are very complex cases, and intracoronary imaging is key to success in this case. So most of these cases we do with two consultants that have got an interest in complex PCI and an interest in intracoronary imaging as well. And also in the cath lab, we've got team members that have got a particular interest in IVUS and the co-registration. So we have that team-based approach. And we find, in these very complex cases, our focus can be fixed, and it's very good having another senior colleague with you to make sure that, you don't lose track of something else that might be going on. So, we've got quite a very strong team-based approach here, based upon the complexity of the case. And also when you've got all the different intracoronary imaging runs you do, you need someone who's going to help that side of things and interpret it while you've got somebody dealing with the PCI. I really don't think this is a one-man job.
Yeah. And obviously, Nick, if I'm very happy to come over and be your second operator, as long as you invite me to see the artwork in your house.
You're most welcome, Paul.
So, Donnie, over to you. Yeah. In Jakarta, I'm sure you see plenty of these type of patients. What's your take-home message for us?
No, I like the last words regarding the team. In my hospital, every complex case should not be decided by a single operator or one operator. It should be past what we call it the heart team conference, involving even the surgeon. So in every complex, so we will decide whether this patient must go to surgery or the PCI. And then I like Bilal mentioned that in my lab, if I face the very complex lesion, so it should be involved for another one or two operators. So we will discuss before the procedure, intra-procedure, and after the procedures. So it enlightening your knowledge and everything. So that's my comments.
Great. Good point. Really good point. I'm going to bring there are a couple of questions that the audience have asked. I'll answer one of them. Any formula to estimate how much contrast to limit in patient with reduced EGFR? So I think we touched on this a few times. I tend to use the same figure. So if EGFR is 30, then you kept it at 30. If EGFR is 25, you try to aim for less than 25. Then I will have a question for, maybe I'll send this question to Jack, who is next to me. How about talking about nailing the ostium with minimal contrast? So how about loading the IVUS on the floating wire to see the ostium when positioning the stent? Height, I think. But.
Yeah, so in general, to do that, you need quite a large size guider, like 8 French. So I wouldn't necessarily think that there's a advantage in doing that. So that's not something I'll advocate. I like the approach of the floating wire, but if you want to do that, you should do that as part of your routine practice first, and not do it in the minimal contrast case.
Yeah. Okay, and on that front, Jack, any important take-home message for our attendees?
So I just like to sum up what I learned from the speakers, actually. I felt that I learned greatly about how to just identify the at-risk patient first. For the pre-procedure part, I think the take-home message for me is as little contrast as safe. Let's not try to go too crazy. The other part is post-procedure, hydration as much as safe. I think Poseidon strategy is quite decent. Intra-procedure, don't forget, do not have the patient become hypotensive. That makes a kidney take a hit. Then the procedure itself, what I learned from the speakers was that you have to be really patient. They showed it like it was nothing, but you have to slow down. You have to watch the distal wire tip. You have to be more careful. You have to do the IVUS carefully. Take time to analyze it and don't rush because it's not routine without contrast. So I think these are some of the take-home messages for me. And of course, practice a skill set that is needed for minimal contrast, your better wiring, your IVUS interpretation, and some of your techniques for gauging the position of osteostenting. Thanks a lot. Yeah.
Okay, so maybe I'll pass it over to my colleague, Dr. Ho, Master Ho, to summarize and then maybe close out the session.
Sorry, Paul. I think we need to address one question that we forgot, was regarding the access. Remember that whether for patient with advanced CKD, what's your preferred vascular access? Is it radial or femoral? So Jack says he prefers femoral. So maybe we can discuss this before we close.
Oh, yeah.
Bilal, do you have any preference? Or?
Yes, so my preference is radial. You've got increased risk of sort of embolization down to the kidneys from the femoral approach. The only balance that you've got here is the trade-off between, is this patient going to end up with requiring dialysis afterwards and the need for a fistula? So that's the trade-off. There is this sort of distal radial technique, distal radial access, which sort of still preserves the radial. Say I've not got much experience in that, but my approach would generally be radial in these patients.
A quick comment from Michael, Nick, and Tony?
We will always ask by our nephrologists to save the radial. So that's why for us, we always go femoral. But recently, we have tried out the distal radial approach, as mentioned by Bilal. And actually, it works quite well. You can actually access through the upper limb and without damaging or impairing any of the radial arteries. You can still save the radial arteries for the nephrology. That's something we can develop in the future.
Yeah, in my case, I would still prefer to do radial because of the fact that kidney patients are high bleeding risk patients. So my default would be radial.
Yeah, in my hospital also, the radial is still the default for this kind of situation. Of course, there was discussion about the RAO, radial occlusion in the future, but not very convincing, I think, in terms of the study. So we're still doing radial as a default.
Okay. So thank you very much for all your comments. So I'll just make a quick summary and before we close. I think the key learning points, for today's webinar is, for patients with advanced CKD, we try our best to perform a successful PCI and prevent contrast-induced nephropathy. So I think prevention is important. So hydration is still a mainstay of therapy. And of course, intracoronary imaging, If you have the Sync Vision system, I think it's a bonus because we see that the features that have been talked about by Bilal and as well as our Life in the Box. So with that, I think I would like to thank my co-chair, Jack and Paul, and all our faculty, Bilal, Michael, Donnie, and Nick. And thank you to all the online audience who joined us in this Saturday afternoon. And I also like to thank our APEC-I Secretariat, Christina and Yilin, for their hard work. A big thanks to Philips for sponsoring today's session. Special thanks to Lydia and Sujin. And I also like to thank Spring Forest Studio for the technical support. So I think with COVID-19 mass vaccination on the way, we hope that we can meet each other again in a physical meeting. So take care and bye-bye.
Thank you.
Bye. Yeah.